So we are once again here for another edition of the Osteopathic Lyceum podcast. What we're going to do today is very specifically utilize the concept of the patient interview to go through a few topics and look at some research. Now, it won't be exhaustive research by any stretch of the imagination. It'll be wave tops so that you sort of get the picture as to why I'm going to speak about this in the fashion that I am. Now, the topics that we'll look at are the concept of psychosomatic reflexes or the psychosomatic relationship or the psychological and somatic relationship with respect to health and disease states, or the ability for psychology to manifest in a physical sense. We're going to talk about pain theories in order to help mesh this together. We're going to also speak about the biopsychosocial model with respect to clinical interface. And we are also going to speak about the theory of constructed emotion. The idea here is to pull from different lines of evidence to point in a particular direction. So if you simply looked at something such as psychosomatic medicine or the psychosomatic reflex, you can think, at least to some degree, that you'd be able to identify specific situations in which the psychology of a patient is the reason they're having a particular pain state. Now, it's not that that is untrue, but sometimes it is not necessarily as useful to look at it that way because it provides you no solutions. So sometimes it's just descriptive. The biopsychosocial model has a very, very explicitly specific epistemology and ontology, so view of reality and view of the truth that maybe don't necessarily serve as directive as well as they'd like to. It is not to undercut the biopsychosocial model and say that it is not what it says it is or that it has no use. It is to say that it is not necessarily as chronically useful as those who are its proponents would like to think. The theory of constructed emotion is probably the thing that is the most up to date and allows us to understand emotion in a much better way so that we can do the thing that good clinicians and good scientists would do, which is actually get into the details and get into the context. So something like the biopsychosocial model would claim that that's what it's doing. However, because of its epistemology, it actually doesn't let you do that on a bedrock fundamental level. Also, the psychological side that would relate itself to the biopsychosocial model was developed at a time when the theory of constructed emotion had not been put forth, and therefore it is not capable at this point of having considered the theory of constructed emotion. The theory of constructed emotion is closer to the bedrock than we've gotten before. It does not mean it's the bedrock, but it means it's closer. And it actually, in some ways, crosses over very nicely with the observation of the biopsychosocial model, but it allows for greater insight. Now, the reason that we're going to pull from all of these things is for a feature called consilience, or pulling from multiple strands of evidence to point in a particular consistent direction. Now, consilience is usually getting to a phenomenon in a more clear way than what we're going to do here, or what we're going to attempt to do here, and that's freely admitted. But if we consider all of these things, we'll get closer and you will understand the importance of being contextual and being investigative and working with the individual that's in front of you to gather information, as opposed to the classic thing to say is take a history, because that intones a what, or the criticism would be that it intones a power dynamic, and that comes from an exceptionally specific epistemology as well, which is not, again, useful the way that it claims to be in healthcare. In healthcare, you actually have to get to the stable, consistent, observable reality as opposed to the individual reality. The individual reality does not allow for agreement. It does not allow for action as much as getting to the stable, consistent, observable reality. So you're essentially talking about positivism versus constructivism. The constructivism is the biopsychosocial model, whereas the theory of constructed emotion acknowledges that in the positivist view, the single reality, people are different and context matters. which is the stable observable reality. So it actually allows you to use those details in that framework to get to somewhere where you could help somebody or be more accurate, as opposed to the biopsychosocial model, which is definitely a constructivist thing. When it is constructivist, it does not allow for the agreement. It's more descriptive, and it very, very heavily relies on or relates to concepts that would be built upon that would suggest everything's about a power dynamic. And that has political implications that we don't absolutely have to touch on, but it should be noted that that's the case. So instead of just rambling on with nothing to see, what I'm going to do is share the screen. And first, we will speak to essentially the biopsychosocial model, right? So actually, we'll do psychosomatics first, okay? So psychosomatics, right? And my computer is likely to give me a little bit of trouble, and that's a little bit better. I'm going to adjust the size of the video window for those who are watching and not simply listening. Now, the resource here is a rough resource, and not everybody's going to love it. It is Wikipedia, but Wikipedia in this case gives us the fundamental concepts and does reference. So should anybody be interested, you can go track down the references that are at the bottom of the page. Now, when you type in psychosomatics, you won't necessarily come to psychosomatic reflex. If you do look at psychosomatic reflexes, there are exceptionally specific conditions that are noted. The thing that comes to my mind is the galvanic reflex. So please excuse me if I don't explain that particularly well, but you will find exceptionally specific things, not a broad thing, which would then suggest to you that there is acknowledgement of the psychosomatic connection or the psychology driving the somatic expression within the allopathic world or the standard medical world, whatever term you prefer to use. The allopathic one is a very old term. Some people don't appreciate it. So you could just say the medical standard. There's lots of ways to describe it, neither here nor there. But psychosomatic medicine, you can see it here. It essentially just acknowledges that there will be times when the psychological factors drive the somatic expression. Now, instead of digging through this exceptionally, just acknowledge that that is something that is contained there. There are definitely times when psychology drives somatic expression. The thing that you would run into here is high levels of anxiety. So a high level of anxiety or something that is making somebody stressed with respect to distress and not eustress. You will see higher levels of perspiration in some, not all, higher levels of respiration in some, not all, higher heart rates compared to norm in some, not all, or some mix of those things. So you will see anxiety driving alterations in physiological frequencies or physiological functions. That is not strange. You can see alterations temporarily in some individuals in things like transit time. So there is definitely the opportunity for psychology or changes in psychology to drive somatic expression. That is completely understood, completely accepted within the standard medical world. They may not necessarily suggest that is omnipresent or the primary cause or the primary lever to pull on with respect to some health conditions. Whereas within the complementary alternative health space, there is a stronger belief that that is the case. So the evidence points to it existing, but not being omnipresent and not being the most appropriate lever to pull on in all cases. As a hands-on osteopathic manual practitioner, you cannot effectively pull on the psychological lever. It does not mean you can't interact with it. It just means that you are neither trained nor legally allowed to work in the psychological realm, unless you have a previous healthcare certification that legally allows you in your jurisdiction to work with some form of psychological interface. So the omnipresent thing in osteopathy is that you cannot interface specifically with psychology on purpose. That said, a good clinician is going to alter their behavior and their demeanor in relation to their patient, the details and the context of their patient. That is what a normal, good clinician does. They pay attention to the individual in front of them. and they adjust accordingly. Their tone, their volume, their frequency, their rhythm of speech, the details which they speak about. So if you happen to notice that something that you say seems to alter a patient's behavior in response to you in a way that you would consider negatively valenced or bad, you change. You don't bulldoze your patient in how you interact with them verbally, because that's the primary thing that's going to give you some insight into the internal state. So you say something and they respond with something. So body language is going to tell you a lot about, or give you a lot of superficial proxies for internal state, but their words are going to make it a little bit more clear. So you have to acknowledge that psychology matters and how you interact with your patient matters. You can understand that patients are not the same. They're highly different, which means I cannot speak to you about a specific way to deal with any patient. I can tell you that you have to respond to your patient. You have to adjust your rhythm, your timing, your frequency, the details of what you say with respect to how your patient responds in the moment. That you will have to do different things with that same patient on a different meeting because they will be contextually influenced in a slightly different way each time. Sometimes their mood may be extremely stable across a lot of clinical interactions. However, there will obviously be times when that's not the case. There will definitely be times when something's happened to them. They've lost a significant other. They've lost a loved one. They've lost a pet. Somebody at work is stressing them out. Their significant other is stressing them out. These are all real things. You are completely capable of interfacing with these things if you are an awake human being in any way and you use your senses. You will pick up on this. As a clinician, you will have no choice but to move towards expertise with this, because if you don't, you will have a bad reputation either in real life or electronically, because people will leave you Google reviews and things of that like. So you have to respond to your patient. This is just what a good clinician does. Now, if we look at the psychosomatic concept and we look at pain theories, so the most recent appropriate explanation of pain or categories of pain came out in 2017. And what you have is nociceptive pain as a category, which means that there is possible or actual damage to tissue. So some form of mechanical interface with tissue has caused an appropriate nociceptive sensation to be transmitted to the brain, to be interpreted, and then often seen as noxious or negatively valenced, right? So it is a negative experience. So that is nociceptive pain, possible or actual tissue damage, appropriate nerve signaling to the brain, patient experiences pain. Neuropathic pain is when there is no notable presence of possible or actual tissue damage, but there is some pathology to the nerve, and the nerve is sending nociceptive signals to the brain to be interpreted as negatively valenced by the patient. Therefore, the experience of pain occurs with no mechanical or actual physical findings related to it other than neural pathology. So it is an inappropriate nociceptive signal from neural pathology. The final category, which was introduced in 2017, is nociplastic pain. Nociplastic pain is the report of pain or the experience of pain in a patient who has no identifiable tissue or mechanical pathology and no identifiable neurological pathology, which then allows us to investigate that category from scratch or de novo. It would be the most appropriate term, to try to understand how that occurs. That is going to, at this point, primarily be a psychological interface. So you can understand that the patient may present you with a report of pain, and pain is a symptom. It is not a sign. A sign is something that everybody can identify, including the patient. A symptom is what only the patient can identify. Pain is a symptom. Now, that can be a symptom of possible or actual tissue damage, so nociceptive pain. It can be a symptom of neurological pathology sending nociceptive signals with no possible or actual tissue damage, which becomes neuropathic pain, or it can be pain reported in the absence of both of those. Now, it would be really easy for someone to be dismissive and say, oh, that means it's all in their head, and that's not the case. We have no idea, or maybe it is the case. We don't know yet. This categories put forth in 2017, investigation must be done. It must be observed in a neutral way, or as neutral as possible, by as many people as possible, repeated as much as possible in order to identify that phenomenon appropriately. But what it shows you is that there is some degree to which, in all likelihood, neuropathic pain and nociceptive pain have a mechanical element because the neuropathic pain has some swelling. So it's possible that with the alteration of muscle tension or the alteration of joint movement capacity, you can impact that by altering pressure gradients. It's possible. It's not necessarily definite. There will be some in which it works. There will be some in which it works mildly, and there will be some in which it doesn't work at all. The same is true of nociceptive pain, where there's possible or actual tissue damage. Well, mechanically, you can interface with that more appropriately. So nociceptive pain and neuropathic pain are likely more appropriate categories for osteopathic practitioners to interface with. Nociplastic pain is undefined. That is where you might find somebody with fibromyalgia. Sometimes it's going to do something positive. Sometimes it's not, right? It is undefined at this point. Now, what I want you to understand is that the acknowledgement of the psychological component, the acknowledgement of the nociplastic category of pain allows you to better understand where you're more likely to get results. You're going to start to gather this information through the patient interview. We'll get into that in a few moments after we go through some of this other stuff. So I'm just going to have to adjust something here so that I can get to the other tabs. So now we're going to look at the biopsychosocial model, okay? So I'm going to see if I can find this relatively quickly. So, okay. So this will actually pop up in the abstract. The abstract will give us what we need. I'm just going to take a sip of something here. So you can definitely look at this paper. So I'll scroll so that you can see. This is from 2004, so it's not brand new, but it is something that did a very, very good job of looking at the state of the literature at that point. I believe this would be a little bit more of a narrative review. I'm not 100% sure about that, so please don't take that as gospel. But essentially, it looked at the state of the literature with respect to the biopsychosocial model and gave a report. It's talked about its history and its development, and some other things about it. But the key point here, so the title of the model is instructive: biological, psychological, and social. So you can see how those are three categories under which you may find information with respect to the context of the individual patient as to why they are experiencing certain things. Now, the biological component would, let's just say we take pain theories, look at specifically the categories of nociceptive and neuropathic pain, whereas the psychological and the social would consider the nociplastic pain, right? So we now have some things to start to line up for better investigation. These are categories. This is how ontology is utilized within the actual scientific method or in the philosophy of science. So ontology in philosophy is the theory of reality or the study of reality, whereas ontology in science or the philosophy of science is essentially the categorization system that allows you to describe things of their own merit and then compare them to one another. So if I had a green square and a green circle, if I had the category of color, green, they're the same. If I have the category of shape, circle versus square, now they are different. That is essentially a very rough, superficial example there. Now, the categories that we're looking at here to see if they are independent constructs or constructs that are measured importantly independently. The biological maps well to neuropathic and nociceptive pain. The psychological and social map well to nociplastic pain. So what you can see is these categories are going to have to dissolve in some way with respect to pain theories. So the biopsychosocial model maybe is just descriptive as opposed to prescriptive, or prescriptive, however, wherever I'm supposed to put that damn R. But you can see how it is not absolutely useful for identifying what to do. It is useful for maybe making a mental model, but it is not useful for identifying what to do because the ability to purposefully observe and identify exactly what's happening is less likely to be described by this, more likely to be described by pain models, because the pain model tells you it's either the tissue, it's the nerve, or it's neither one of those. So it covers these, right? So the pain theory model is actually more instructive as opposed to just telling you a story. Now, the reason I'm going to say that with the biopsychosocial model, it absolutely has value, but it is not necessarily clinically directive. Okay. So there is something here that I'm going to highlight. So, okay. I'm going to read from here, right? So it's at the practical level is a way of understanding the patient's subjective experience as an essential contributor to accurate diagnosis, health outcomes, and humane care. So that's where it's valuable. But that is normal clinical behavior when you've been in clinic for any length of time because you have to adjust your behavior in relation to the response of the patient. We've already discussed that. That doesn't require a model. That is normal behavior for clinicians. Okay. It is abnormal when a clinician does not do that. That clinician will have a lot of legal problems. You can find them by searching legal cases. In this article, we defend the biopsychosocial model as a necessary contribution to the scientific clinical method while suggesting three clarifications. The relationship between mental and physical aspects of health is complex. Yes, subjective experience depends on, but is not reducible to laws of physiology. Models of circular causality must be tempered by linear approximations when considering treatment options, and three, promoting a more participatory clinician-patient relationship is in keeping with current Western cultural tendencies, but may not be universally accepted. We propose a biopsychosocial-oriented clinical practice whose pillars include self-awareness, active cultivation of trust, and an emotional style characterized by empathic curiosity, self-calibration as a way to reduce bias. That's a big problem. It doesn't work. I'm not going to go into that here, but that just doesn't work. And that's from medical error reduction literature. Educating emotions to assist with diagnosis and forming therapeutic relationships using informed intuition. Intuition is not what people think it is. That is from clinical decision making. I'm not going to go into that here. That falls apart right away. Communicating clinical evidence to foster dialogue, not just the mechanical application of protocol. Okay. That all sounds absolutely fantastic. It is the initial thing, the subjective experience of the patient as dictating, at least to some degree, or influencing health outcomes and patient outcomes. That is completely correct. You will not find a clinician who meaningfully argues with that unless they are a clinician scientist with an exceptionally specific epistemological and ontological outlook rather. Because this focuses on the subjective, it is constructivist. It is not possible for it to be anything other than or constructivist. It's not possible for it to be anything other than constructivist. So constructivism centrally holds that the truth or reality is dependent upon the individual, their previous experiences, and their environment of observation. That is correct. However, that does not allow a healthcare practitioner other than a psychologist or somebody who's clinically and legally allowed to interface in the psychological realm to do anything. Somebody who's working in the physical realm, such as an osteopathic manual practitioner, has no tools there unless they have other certifications that allow them to interface in the psychological realm. We have physical tools, okay? Regardless of what a practitioner prefers, the subjective experience of the patient or the objective reality of change in the patient, whether it's subjective change or objective change. That is constructivist by its nature. Constructivism does not fundamentally allow for agreement between individuals. It basically means that every experience is brand new and you have to start from absolute scratch. Pattern recognition is not a thing, right? In the worldview of the practitioner and the worldview of the patient never really cross over, except for the fact that they suggest that you co-create your reality. And that's a new reality. It's a reality that is dependent on both of you, but independent of both of you. Okay, philosophically, you can see how this is a gigantic mess. Now, it sounds exceptionally useful. Okay. It sounds very caring. And in its presentation, that is completely understandable. In its application, it pulls a physical practitioner away from physical reality. Osteopathy is not done in the psychological realm. It does not mean it does not acknowledge or respect the psychological realm. Sometimes the physical sensation that the patient is having, so somato-psycho reflex, somatic first, psychological second, is a real thing. Therefore, the alteration of the physical, the somatic, will have some positive impact on the psychological, not the other way around for the osteopathic manual practitioner. Okay, I need you to understand that fundamentally. You don't go psychological in your interface, you go physical, right? That is what you are trained to do. That's what you are legally allowed to do. That's what you are bound to do, unless you have appropriate other training and certification. Okay. So the biopsychosocial model is constructivist. The biopsychosocial model is not prescriptive. It is descriptive. It just talks about how you co-create reality. That's a big no-duh moment. That happens all the time. That is human interaction. Constructivism actually does a really good job fundamentally, or really not fundamentally, superficially describing thinking. Thinking is completely dependent on details. Therefore, it is dependent on the details that the individual has. Their previous experience provide them those details. Their current environmental observation provides them new details. So this is a big mix of things that then creates thought, creates emotion, because emotion comes from thought. And I'll show you how that happens in a moment. But that's what that is. The biopsychosocial model is a big no-duh. Okay. The practitioner and the patient are always co-creating. Now, if the practitioner is a dink and a jerk and not paying attention to the patient, which does happen, then there's a problem. That will show up in legal problems and poor health outcomes. Most clinicians are going to move towards good patient interactions that are completely contextually dependent upon the interaction between them. That is common. That is also expertise. They need to know they made an error. So they need to actually pay attention to the cues. So they need to be more of a positivist. They need to see what's happening in ground reality, what's happening between me and this person. They need to know they made a mistake. If you don't know you made a mistake, you can't correct it. That's why supervision is important, because the supervisor can tell you you made a mistake. And then when you know you made the mistake, you can correct it. Okay. The biopsychosocial model doesn't allow for this. The biopsychosocial model is grounded in a view of reality that does not allow that. Again, that is not undercutting the value of the biopsychosocial model. It has value. It has helped a lot of practitioners get a lot better at patient interaction. That is important. But for a clinician in the physical realm, such as an osteopathic manual practitioner, this is not the most useful way to go. I understand that it is a common discussion point within the profession. Just because it's common doesn't mean it doesn't have flaws and problems in its underlying assumptions. We've already noted how pain theories are actually more useful for investigation because it dissolves this model. This model is just describing where you should look, right? So should you look biologically, such as neuropathic pain or nociceptive pain, or should you look psychologically and socially, such as nociplastic pain? Okay. Pain theories do this better for a clinician. If it is nociplastic pain, as an osteopathic practitioner who does not have further certification in interfacing psychologically, that's referral. That's where you send out. Okay. Now, I'm going to talk to you about the theory of constructed emotion and why, as an osteopathic practitioner, or even as somebody who buys into the biopsychosocial model, you need to reconsider very heavily how you view emotions. Okay. Now, I'm going to show you again, as I consistently do, the wave tops here. Okay? I'm not necessarily going to read through this whole article and show you everything because that can be tedious. Okay? The article is essentially the big introductory article with respect to the theory of constructed motion. So the title is Theory of Constructed Motion, an active inference account of interoception and categorization. Okay, those are exceptionally important terms. Now, in the title, this is the theory of constructed emotion, and this is based on neuroscience, and it is acknowledging that thinking cognition is detail dependent. Those details come from the biological side and the outside world. So the outside world is sensed and turned inwards, and interoception, right? So interoception really is the sensing of the internal environment, but so that basically means that your physiology, and this is what can turn a lot of osteopathic practitioners on, what your intestines are doing isn't consciously sensed, but it is sensed. And it does impact how your brain functions with respect to body budgeting and body control, right? So if there's some degree to which, in a mechanical sense, so you can use mechanotransduction to alter how the body is functioning, the mechanotransduced signals from the intestines can then alter what the brain is doing. Because if the signal is going one way and you change the signal, there you go. So there's some mechanistic thing to explore. It doesn't mean it properly describes the mechanism of action for osteopathy. However, it pulls from research that could be useful. Okay, so this is suggesting that thinking is constructivist. Thinking depends on the details of the individual, which would include the external sensory environment, the internal sensory environment, the bio. Okay, then it is interpreted, right? Active inference. There's an interpretation done by the human brain in relation to the biological environment. The categorization is where the emotion comes in. Okay, so I'm going to read you the abstract and then give you some insight. This is from 2017. There's been progress on this. The science of emotion has been using folk psychology categories derived, and this is ontology. Okay, this is how you try to understand reality, derived from philosophy to search for the brain basis of emotion. The last 2 decades of neuroscience research have brought us to the brink of a paradigm shift in understanding the workings of the brain. However, setting the stage to revolutionize our understanding of what emotions are and how they work, in this article, we begin with the structure and function of the brain, and from there we deduce what the biological basis of emotions might be. This is not a firm statement. I'm pausing here. You have to understand that uncertainty is built into this. That is good scientific behavior. To return to the final sentence, the answer is a brain-based computational account called the theory of constructed emotion. Okay. Now, what the theory of constructed emotion puts forth, and you will hear Dr. Lisa Feldman Barrett, who is the person who developed this in concert with collaborators, but she is the driver here. She will use the example of a scowl. Okay, so a scowl in many circumstances is automatically assumed through culture to relate to anger or be an external expression of anger. If you look at research, what you will find is that about 30% of the time, a scowl is anger, which means that 70% of the time it is something else. Okay, so I'm going to take a sip of something. What needs to be acknowledged is that, and this is how you kind of get to the categorization, the inference portion of the title, the category that is used by an individual or many others is culturally bound, it is contextually bound, which means that it is not the same location to location, group to group. There's a lot of crossover, but it's not the same. One culture may not have a term for a particular emotion that another culture does. That means that that culture has provided another category for interpretation or inference as to what a physical sensation means. Okay, so anger is the category. If you look at the expression of anger, what you find is that it will be reported to relate to a scowl 30% of the time, and then that scowl is related to some other category 70% of the time, or other set of categories, which means that there will be words which behave as categories, which have a variety of expressions. So somebody can be angry at somebody and laughing hysterically. Somebody can be angry at somebody and crying. Somebody can be angry at somebody and completely stoic or neutral. Somebody can be angry at somebody and their heart rate will go up. Somebody can be angry at somebody and their heart rate will stay the same. Somebody can be angry and their heart rate will go down. Somebody can be angry and their perspiration will go up, down, neutral. Their respiration will go up, down, neutral. Their skin conductance will go up, down, neutral, which means there is no stable signature of emotion generally. People as individuals will have patterns, but you have to have that data over time to figure out their patterns. But an individual can deviate from their pattern. They can deviate from their norm. So emotions, in essence, are interpretations of sense data. Okay. which is this groovy thing for osteopathic practitioners, which is why I say osteopathic practitioners can work on the soma. They can work on the somatic side of the somato-psycho reflex. They cannot, by training or view of the world or interface with the patient, interface with the psycho, right? They can't go brain to body. It's not what you're qualified to do. But you must acknowledge that the psychology happens. Now, this is where we flip a little bit. So before we flip, you can see that first, to believe the biopsychosocial model, you have to believe previous views of emotion because it was built with the assumption that previous views of emotion, as here are called folk psychology categories, you have to believe that that was correct. We now know that that's incorrect, right? So you can't buy the biopsychosocial model there. The biopsychosocial model is descriptive, is not prescriptive. They will claim it's prescriptive, but it can't be because it's constructivist, okay? This suggests that constructivism is a feature in a positivist lens. So believing that there is a singular reality that can be identified through appropriate experimentation. Appropriate experimentation has showed that there is variability within a given category of emotion, right? So it supports, you can get into an argument and say, well, that is constructivism, and it's positivism. Positivism acknowledges the variation, right? The stable reality is that it's a variable. So you can't buy the biopsychosocial model because it made, at minimum, an assumption about emotion. You can't interface with emotion the same way that you would have previously if you acknowledge that the theory of constructed emotion exists. Now you have to acknowledge that you have to ask somebody about their expression, and you have to buy that what they're telling you is accurate. And then what's going to happen over time, as you know that person more, you'll find their pattern when they're being inaccurate or they're reporting something they want you to think versus what's actually happening. You pick that up through pattern recognition. Pattern recognition is the essential component of any healthcare. Pattern recognition can be a problem, though, when you get good at a particular pattern that you recognize, because if you stick with that pattern, you'll miss what else is happening. So you actually have to pull back. So the problem with expertise is that you start to ignore things that never work. But sometimes they do work, you just haven't found it yet. The novice does everything and doesn't know what to pay attention to, okay? So this informs the patient interview because now you know, based on emotion, you have no choice but to pay attention to that individual. You cannot make the assumption. You now know you can't make the assumption because of the theory of constructed emotion. The theory of constructed emotion lets you dissolve the biopsychosocial model, but it doesn't let you dissolve pain theories. Pain theories allow you to figure out whether or not the patient is more or less likely superficially to be amenable to your treatment, okay? The nociplastic patient with no possible or actual damage to tissue or no neurological pathology is less likely to be amenable to physical treatment. You will less likely get the somato-psycho loop, okay? Now, the patient interview, here's the deal. You now know you have to ask questions of variable individuals and the same individual will vary time to time, okay? You are required ethically to get as much information about the state of the patient as you can, psychologically, emotionally, and physically. That is a requirement. So you can say that that relates well to the biopsychosocial model, and if it turns your crank, that's cool. But gathering that information allows you to utilize the categories of pain theory to figure out which bucket that person's in and start to figure out whether or not you need to work with another healthcare practitioner for that patient. Ethically, you are required to explain what you're going to do and what its possible benefits and negative outcomes will be. That is ethics, okay? So ethics actually covers the patient interview exceptionally well because you are required to tell them what to do. You are required to provide them autonomy. You are required to allow them to express themselves in the way that they need to. And this is literally a requirement of healthcare. So ethics, your ethical duty in healthcare, does a better job of guiding the patient interview than the biopsychosocial model. Ethically, you need to ask questions of the patient to be informed about their state, about their complaint, about their subjective symptoms. That's required of you. You are also required to gather their objective signs. You are then going to have to piece that information together to figure out what to do or whether or not you should do something. That is guided well by contraindications and red flags. So you already, at this point, have all these tools that doesn't require you dabbling in the psychological realm. You do need to acknowledge when somebody is reporting things that make you think that they're psychologically having some form of identifiable challenge that another practitioner would be better off at. So if the patient seems agitated, if the patient seems standoffish, if the patient seems reluctant to answer questions, if the patient is being very aggressive with you, if the patient is upset, if the patient informs you that they feel like you're not paying attention, okay? These are things where you need to acknowledge that you may not be the best fit for that patient and that they may need some other form of help. Now, when you speak to somebody about whether or not they should consider some form of psychological interface, they may not appreciate it. So you've got to get good at that. I can't tell you the details of that because it's going to depend on that patient. That's where constructivism does a good job. You have to pay attention to the subjective characteristics. Positivism does a good job with that because it tells you that that's the stable truth, that people are variable. Okay. So you're going to have to learn how to ask questions. You're going to have to learn how to ask in varying ways how a patient is doing, right? How are they feeling psychologically and emotionally? How are they feeling physically? What is their stress level like? Are there things that are bothering them? You might have to use humor to get this information. You're going to have to ask them what their primary concern is, okay? You're going to have to find different ways to ask them what they're hoping to get. If they say pain relief, as an osteopathic practitioner that understands science, you're going to have to say, hey, I work on movement. And sometimes the movement side, when we get it to change, it is very well related to your sensation that you don't like. And they'll change together. And sometimes they won't. We'll figure that out really quickly because when I get you moving better, if you don't feel any different within some reasonable time frame, we're going to acknowledge that and say, hey, maybe you need a different form of healthcare, right? You're still going to benefit from the alteration in movement or the improvement in movement, but it might not be the thing that changes your sensation because if your goal is your sensation, and this is where you need to negotiate the goals with the patient. The patient needs to be free to tell you what they want. You need to be free to tell them whether or not that is likely. If a patient has a torn biceps tendon, osteopathy is not necessarily going to fix it. That is torn. That if you treat that tear, you are ignoring red flags and contraindications. You do not move a known tear, right? So they have to be free to tell you what their goals are. You need to be free to tell them whether or not you can help them with that. You can treat the patient, but not the tear. You can treat the patient, but not the break. You need to actually tell them that. That is a skill set that you're going to have to develop. If you're in an educational setting, your educational provider will teach you that. But the details of how they teach you that are variable. That is a challenge, okay? Now, they're going to likely be adaptable enough and skilled enough to teach you as the individual how to do that. If you're a current practitioner, you have figured this out through essentially implicit learning by mistake over time, okay? You are going to have to build the ability to gather this information, to think through it. Now, most people will tell you that you need to be able to make a differential diagnosis. Yes, you do. Differential diagnosis is a skill that is developed over time, but you have to have some category to put it in, which is why I say pain theories are important, which is why I say the theory of constructed emotion is important, right? Which is why a physical assessment is important. Okay? Those are the skills you should be focusing on as an osteopathic manual practitioner. So again, you've got to negotiate. The patient has to be free to tell you what they want, what's bothering them. You have to listen to it and you have to piece through it. People will tell you that clinically you need to use critical thinking. I have done a piece in the past where I tell you why critical thinking is not a thing. Thinking is heavily detail oriented. It requires details. Therefore, it is incumbent upon you to develop the skills to get the information or to gather the information in a respectful way to the individual you're dealing with. If they don't want to give it to you, you're not their practitioner. You can't help them appropriately. You must be able to acknowledge that. Okay. So there's a lot of stuff going on here in this piece, in this discussion. To try to wrap it up, okay, you're going to have to learn how to ask the same question with a lot of different words, ask a lot of different questions to the same person, because you have to respect that they are a unique individual who's presenting in a unique way at that time. You're going to build rapport with them. You're going to notice their patterns. That's where you're going to get better at understanding them. That is well supported by the theory of constructed emotion. Your initial interface with them is going to allow you, from your interview and your good or what developing skills in asking them questions to gather information, is going to allow you to help understand whether they are more likely in the nociceptive category, the neuropathic category, or the nociplastic category. Once you understand that, that is your differential diagnosis. You don't have to differentiate which bone, which muscle. You just have to say, hey, is something not moving? If something's not moving that good, that's obvious. Then you can say, this person is amenable to my physical intervention. If the person is moving relatively well, but they present you or they report to you neurological symptoms, you can say, hey, maybe there's neural inflammation. Maybe there's a mechanical thing that I can do to alter tension and pressure through a particular region that can have a benefit for this person. And then that's where you have to experiment to see. That's differential diagnosis. If the person has no understandable trauma to tissue at any point, no report of neurological sensation when you move them in the presence of good movement, because that's a differential diagnosis for it possibly being neurological. So if they don't have those two, then it's nociplastic. Now you need to work with another practitioner. Okay, so the biopsychosocial model has been useful to a lot of people. It is not clinically instructive in the way that one would hope. Pain theory is better. Okay, the categories at least, maybe not the particular instructions that are related in the literature to that. The theory of constructed emotion allows you to understand a stable phenomenon that people will report the same word, but it will be a very different expression. It will be a different expression when patient A reports word B, right? So patient A reports word B time 1, it means one thing. Patient A reports word B time 2, it's a different expression, okay? The patient is variable with the same word. That's why cognition and context matter, because you can't hear the same word and assume the same thing. When you hear the same word, you still have to investigate it. That's ethically required. Patient B will report word B and mean something different than patient A. And this goes on ad nauseum. So now you know that there's variability, and it is ethically required of you to develop the skill set, which is a variable skill set, to gather verbal information, reported information, and physical information, and look at those and say, is this more likely a physical phenomenon in the form of a lack of motion? Is this a physical phenomenon with respect to good motion in the presence of reported neurological symptoms? Or is this good movement, no neurological symptoms, but a report of pain? When you have that, that's DDX, okay? This is something that in any educational institution, you're going to accidentally get this information or purposefully get this information. So hopefully that was useful. And for those of you who stuck with me the whole way, you have a better understanding of information that's pointing in a particular direction, and which information is more useful to an osteopathic practitioner and which information is less useful to an osteopathic practitioner. The information that is more useful clinically is pain theory and the theory of constructed emotion. Dabbling in the psychological realm is not your thing unless you are appropriately qualified, because in most jurisdictions you are not legally allowed. Don't dabble there unless you plan on getting the certification and have already got it and legally are allowed to do it. So again, thank you. Hopefully that was useful.